Well, thank you so much for the invitation to speak. It's a pleasure to be here. That was a terrific and really moving patient story, and I think really fitting as a great introduction to what I'm going to talk about, to show about the importance of antibiotic stewardship in the outpatient setting. So just quick background. I am a pediatrician. My clinical focus is in pediatric infectious diseases. I work at Children's Hospital of Philadelphia and University of Pennsylvania. And I direct the inpatient antimicrobial stewardship program there. But I do a lot of epidemiology research and somewhat recently have gotten into the field, into the area of outpatient stewardship. And so now do some QI work as well as research in the outpatient setting. So I am from Philadelphia. I know we don't have a great reputation in the state of Minnesota. But I've lived in Philly for a while, but I'm actually from Massachusetts, and I'm a Patriots fan, which was hard to deal with in Philadelphia. But I'm a little friendlier than the folks down there. So, anyways, I have no conflicts of interest. I think you have your learning objectives printed somewhere there. And this is a quick outline of what I'm going to talk about. I'm happy to talk about more. You can stop me or ask questions after as they arise. So I want to try to make the case for outpatient stewardship. It probably won't be a tough sell with this crowd. I want to talk about a specific study, some work that we've done at Penn and Children's Hospital Philadelphia to generate what we think is an important target for outpatient stewardship, talk about some implementation and intervention that we've done, and then talk about some novel stewardship approaches that other folks have done that I think are really promising. Okay, so this is Philadelphia in the background, and I don't know if anyone can see the foreground here. This is a place called Eastern State Penitentiary, which was a super famous prison a long time ago. It's closed for almost 50 years. It's now a national historical landmark. And it's actually, you can go and they do tours, and actually has the best haunted house you've ever seen before. So if you're in Philadelphia around October, you should go here. But you're wondering why I'm showing you a penitentiary. And in addition to being a great place, because they actually were really progressive in reforming the way people were incarcerated, to actually reform and help them instead of just sticking them in terrible cells. They actually house some famous criminals. So Al Capone, and this man here. Does anyone know who this man is? So this is Willie Sutton. Willie Sutton was a famous bank robber. And again, you're wondering where I'm going with this. But Willie Sutton helped me think about why you want to focus on outpatient stewardship. So when asked why he robbed banks, Willie Sutton famously said, because that's where the money is. And when you think about antibiotic use, right, more than 90% of antibiotic use is in the outpatient setting. But most of our efforts and a lot of the regulatory work has been on the inpatient setting. And it makes sense because it's a little bit more of it's much more of a captive audience, and that's where we see a lot of the multi-drug resistant pathogens and lots of the quote unquote big gun antibiotics. But again, more than 90% of human antibiotic consumption is in the outpatient setting. Prescriptions at places like urgent care for pink eye, which even though it was, and I don't know, of course, but even though it was the worst case of pink eye ever, I still would question whether that case needed systemic antibiotics, right? So probably not. But this is where antibiotics are given most of the time. Okay, so just to build on that and give you some scope of the problem, this is a paper done by Lori Hicks and colleagues at CDC, published a few years ago, 2 or 3 years ago now, looking at using the IMS Health database, which is a great database that essentially has 100% capture of antibiotic prescribing in the outpatient setting. And in 2011, that's when the most recent data were available, we saw more than 260 million antibiotic prescriptions in the United States in 1 year. So right there are only about 310 million people or 320 million people. So 842 prescriptions per person. I'm a pediatrician, so about a third of those, almost a third of those were in kids. And in kids, it's more like 1.5 to 2 prescriptions per child per year, right? So we use a lot. And I'll focus again on kids. When you look, just to give, because these numbers are hard to think about, where should the number be? We have a lot of people, and maybe those numbers are right. But using comparative epidemiologic data, you can help. So you can help think about it. This is a paper published a few years back in Pediatrics, which shows the top 6 most commonly prescribed medications to children. Okay, so the big heavy hitters: asthma, ADHD, cough, cold, pain medications. The top line is systemic, not topical, antibiotics. So blows everything else away. It's not even close. 75 million prescriptions per year just to children. So we really use them a ton. And you might say, okay, again, we have a lot of infections and we need them. But if, again, looking at the comparative data, if you look again in the United States, and this is 1 year later, I said 842, the next year was 833 prescriptions per person. If you compare that to another developed country with a first world healthcare system, I would argue that is better than our healthcare system. That's Sweden. They prescribe 388 prescriptions per 1,000 people. And they think that's too high. Their version of the CDC has set a goal of 250, okay? And they're going to meet that goal if they already haven't. And I don't think people are dropping dead from colds in Sweden. So we're not doing really well, and I've shown you in the 0 to 2 age range, in the 3 to 9 year age range, it's even higher. Again, over 1 prescription per child, 1,300 per 1,000, and it's much lower in Sweden. And it's not just quantity, it's also quality, right? So all antibiotics aren't created equal. We have, this is an oversimplification, but we have narrower spectrum agents and broad spectrum agents. And if you look at the 3 most frequently prescribed broad spectrum antibiotics, quinolones, your Cipro and your Levaquin, macrolides, the famous Z-Pak, greatest marketing in antibiotic history, and then cephalosporins. We're prescribing quinolones 4 times more often in Sweden, more than 10 times the macrolides, 10 times the cephalosporins. So we're not only over-prescribing antibiotics in general, but we're actually prescribing broad-spectrum drugs much more commonly. And so another way to look at this and to try to get, again, we don't know the exact number, but comparative data are helpful. And this is a study looking across our Children's Hospital Philadelphia practice network. So we have 31 now primary care practices. This shows 25. These are community-based primary care practices. Luckily for me and other researchers, they all have a common electronic health record, so we can pull their data. And if you look at when somebody has an acute respiratory infection, a patient comes with a respiratory infection, what proportion of those patients are prescribed a broad spectrum, or here you can call it a second line, or in most cases unnecessary antibiotic. And when you look across practices, it goes from 15% to more than 50%. And these are tens of thousands of visits. So these are not, this isn't somebody who saw, 2 out of 3 or 1 out of 10. These are highly statistically significant, and these are standardized. So these are adjusted for the age, the sex, the race, the insurance type. We've excluded anybody with a complex chronic medical condition, anyone who's received an antibiotic in the prior 3 months, and anyone with an antibiotic allergy. So these are essentially, if you do the epi and you do the analysis, these are taking the same patient and putting them at different practices, and they're being treated completely differently. So we don't do this very well. And I don't want to just pick on kids. So this is adult data from Jeff Linder, who's a real leader in the area of outpatient antibiotic stewardship. And this looks at antibiotic prescribing for acute bronchitis in adults, anyone greater than 18. So what should the prescribing rate be for acute bronchitis in adults? Should be 0. Okay, there have been more than a dozen randomized clinical trials of antibiotics versus placebo for patients with acute bronchitis, and there's never been a difference has never been shown. So it doesn't help. Yet over this 20-year period, we still prescribe in either primary care setting, the emergency department, about 75% of our 75% of our patients get antibiotic prescriptions for this condition. But antibiotics are wonderful, right? And these are quotes that we have. I work closely with Julie Simzak. I'll show some work from her. She's a PhD sociologist who's a qualitative researcher. who has an interest in antibiotic stewardship, and she often goes to the front lines, whether it's a primary care setting, in patient waiting rooms, on the wards of busy inpatient units, and talks to people. And this is one where she's just got some quotes from parents, right? So I'm a fan of antibiotics just because the fact that it does heal them pretty quickly. I think they're wonderful. They clear up things quickly. All I can say is they work. So we have this perception. A lot of patients have this perception, and I'll talk a little bit more about that they are so great. But there are downsides. And again, I'm kind of preaching to the choir, but I'll review some of these important downsides. The first thing we think about around antibiotic stewardship is resistance, right? So antibiotic use drives antibiotic resistance. That's it. That's what happens. That's how it works. And bacteria have shown the ability to become resistant to every antibiotic that's ever been developed. And in fact, there have been some really interesting studies where they've gone to a science paper a few years back where they've gone into caves where humans had never been, and they've dug up the bacteria and done DNA sequencing and found resistance to antibiotics or mechanisms that haven't even come to market yet. So they're just out there waiting for us to use them, and they become resistant. Once you put a new drug in the market, you see resistance within a year or two. There are a few exceptions to that. And CDC has appropriately developed a terrific report. It's free online, and estimated that more than 2 million patients are sickened with antibiotic-resistant infections each year, leading to 23,000 deaths. These are vast underestimates. These are just what's reported. 250,000 cases of C. difficile, at least 14,000 deaths from C. difficile. So people die from C. difficile, as many in the room know, and this is really a problem. But I think it's really important from both a scientific but also a practical perspective to think about the individual harm. And this is why Caitlin's story is so powerful, right? So when you're in a room with a patient, whether it's in primary care or urgent care or on the wards of an inpatient unit, it's hard to think about the public health impact of antibiotic resistance when you're giving that one prescription to that one sick child or that sick adult. Okay, and it's hard to think about that, and it's hard for that interaction to really capture that. We should always be thinking about that as public health experts, but it's hard to do that. So we need to think about, and we need to quantify, is the individual harm that antibiotics can cause. So up to a quarter of patients who receive an antibiotic will have antibiotic-associated diarrhea. I mean, in the least, that's annoying, and it keeps kids home from work and parents home from work sometimes. But in the worst, it could be C. difficile, a small but significant percentage of C. difficile, which can be life-threatening. When you look, 1 in 1,000 patients who receive an antibiotic will go to the emergency department for an acute adverse drug effect from that antibiotic. And you say, well, 1 in 1,000, that's not a big number, but that's the same rate as drugs like warfarin and digoxin, the drugs that we worry about the most in terms of toxicity. And also, there are some nice public health data out of the UK where if you give somebody an antibiotic for an acute respiratory infection, bacterial or viral, even things like otitis media, strep throat, peritonsillar abscess, you actually have a 1 in 4,000 chance you'll actually prevent serious harm in that patient. Things like, that people worry about getting strep throat, getting a peritonsillar abscess or getting mastoiditis. So we have some numbers that actually don't really favor the use of antibiotics in some of these common conditions. And then there's the microbiome. So who's heard of the microbiome? Okay, good. It's becoming more and more popular, right? So the microbiome is basically the bacteria that live in and on us. Most of it's in our gut. And your body is mostly microbes. This is a fact, and some people get freaked out by this, but for every human cell, there are 5 to 10 bacterial cells in and on your body. That's it. So we are mostly microbes. 100 times more bacterial genes and more than 1,000 different species in and on your body. And it turns out that these are important. And so this is a nice review article, but we used to think, okay, the bacteria just kind of live there, and they don't cause problems. We don't bother them, they don't bother us, and maybe they make a little vitamin K. But there's a lot more that goes on. I mean, regulation of metabolism, I don't know if anyone's seen some of the amazing studies they've done in animals to show that when you give mice antibiotics, they get fatter than the mice that get placebo. And actually, you can give mice antibiotics and just take their stool and do a stool transplant into mice who didn't get antibiotics, and they get fatter than the mice who get stool transplants from non-antibiotic receiving mice. And they've gone even farther to show that if you take humans that are discordant, that human twins that one is obese and one is lean, and you take their stool and you give it to mice. The mice that the mice follow that phenotype. So the ones who get it from the stay lean and the ones who get it from the obese twin, so there's a lot going on here. And I think development and regulation of the immune system is a really important one to pay attention to, because it turns out that the microbes in your gut educate the immune cells in your gut for life. And that's important because, as you know, your immune system is really important, but also it can be related. There have been some associations with the changing microbiome and autoimmune diseases, chronic diseases. A lot of this research is early, and we don't know all the cause and effect, but it's fairly profound. And prevention and invasion of growth of pathogens, C. diff, is the perfect example there. So I am not a microbiome scientist, but this is your incredibly basic primer on the microbiome. It's pretty complicated, but diversity is good, right? Diversity is always a good thing in pretty much every walk of life, but diversity is good. And I've stolen a couple slides from Dan Knights, who actually is a collaborator of mine. He's a computer scientist and microbiome expert at the University of Minnesota. He has a great website with a really good primer for those of you that are not microbiome scientists. But I borrowed these slides. So this is your gut, and this is this diverse ecosystem representing all the bacteria in your gut. And this is your gut on drugs, right? So you take oral antibiotics. Many of them go right through the gut, and you can completely destroy this complex and what is considered more and more important healthy ecosystem. And then the problem is, okay, you can grow it back because bacteria grow quickly, but it can lead to this. And this looks like a beautiful photo, right? But this lack of diversity has been associated with harm, both acute and chronic illness, and we want to avoid that. So these are the individual potential harms from antibiotics that we have to think about as prescribers, as public health experts, and as patients when we think about the decision to make antibiotics. So this was the cover of a New York Times Sunday magazine article. Some people may have read a few years back. This kid is doing the best they can to populate their microbiome, and then we go and give them Augmentin or Z-Pak and ruin everything, all the work that they've done. Okay, so I want to shift gears and talk a little bit about, there are multiple different ways to address antibiotic stewardship. And I'm going to talk a little bit about implementation approaches that we've taken and that others have taken. But more foundational than that is to do the research and do the studies to find out when you should be using drugs, and if so, which drugs you should be giving. So I want to talk a little bit about the concept of broad-spectrum antibiotics that I brought up before. So this, I'm going to talk about a study that we did. I'm going to talk about it in 5 slides, 4 years of work in 5 slides. It hurts me to do that. But this is called the series study, Comparative Effectiveness of Antibiotics for Respiratory Infections. Most important is the study team, and we got this together. This is a PCORI-funded study, so the Patient-Centered Outcomes Research Institute, which is a terrific funding organization that comes off of the Affordable Care Act that hopefully will stick around. And it was truly a multidisciplinary team. We have folks in the Family Advisory Council at our hospital, so these are parents of children with chronic diseases, primary care doctors, infectious diseases, epidemiologists, biostats, and others. And so just by way of background, why would we want to compare broad versus narrow spectrum antibiotics? Well, I think hopefully I've given you some compelling reasons, but in pediatrics, and it's fairly similar in adult medicine, the concepts are all the same. In pediatrics, it's pretty straightforward because these 3 conditions, acute otitis media, acute sinusitis, and strep throat account for about 70% of all antibiotics prescribed to kids. So, these are the low-hanging fruit here. And, you'd think it's so bread and butter, you'd think that pediatricians did it really well. But it turns out that they don't, and we don't, and that some of it's because the guidance isn't very good. So the American Academy of Pediatrics recommends amoxicillin for acute otitis media. But a couple of years ago, 2 very high-profile, large New England Journal published randomized controlled trial compared broad-spectrum, the amoxiclav, broad-spectrum agent, or Augmentin, to placebo. So that sent a strange message or a confusing message to practitioners. For sinus infections, the American Academy of Pediatrics recommends amoxicillin, but the Infectious Disease Society of America recommends amoxicillin clavulanate. So that's not great. And then strep throat, I don't know if people have seen, but strep throat is, there has never in the history of the world been a clinical isolate of group A strep resistant to penicillin. That's amazing. You can't say that for any other, yet we use all types of things like azithromycin. There's arguments that cephalosporins are better because of shared beta-lactamases, which has actually never been proven, but people are prescribing different medications. So we thought this would be a good place to start. Also, pneumococcal vaccination, as you know, 20 years ago, there was no pneumococcal vaccination. Then we had a 7-valent, then a 10-valent, now a 13-valent vaccine, which is great. And there's some evidence that we're getting rid of pneumococcal colonization and replacing it with other bugs like H. fluorexella that are more likely to produce beta-lactamases. And so could this resistance lead to the need for broader spectrum antibiotics? And then, oh yeah, by the way, 50% of antibiotic use for children is broad spectrum, which is probably not appropriate. And I showed you this slide before. We're not doing it very well. So hopefully I've made the case that it's good to compare these drugs. So what we did, as I mentioned, we have this large network of primary care practices that are all affiliated with Children's Hospital Philadelphia. We did a prospective cohort study from 2015 to 2016 in 31 of these practices, kids aged 6 months to 12 years, who were diagnosed with acute respiratory tract infection, so the ones I talked about, otitis media, strep throat, sinusitis, and prescribed an antibiotic. We excluded patients who had multiple different conditions, some other, if you had a skin soft tissue infection or UTI, you were out of it, and anyone who got recent antibiotics. We thought that confused the picture. And then the thing that made this a large and sort of resource-intensive study is that instead of just looking at the health records or reviewing charts, we actually called parents of patients because we wanted to really find out what the outcomes were. So we called them 5 days after their diagnosis, enrolled them, and then we did 2 structured telephone interviews at day 5 and day 14 after their diagnosis. Our exposures here were pretty simple: narrow spectrum, penicillin or amoxicillin, because they're first-line recommended agents for the conditions I've talked about, and then broad spectrum antibiotics, augmentin, cephalosporins, ceftonir or Omnicef is the most common one there, and then macrolides and Z-Pak, with Z-Pak or azithromycin dominates there. And so I think the key to this study in its patient-centeredness was our outcomes. So this is a picture of Julie Simzak, who I mentioned before. She's a PhD sociologist with interest in antibiotic stewardship. And to first figure out what outcomes we should look at, because kids with, just like adults with acute respiratory infections, they're not dying from those. They're not going to the hospital from those. It's incredibly rare. So we want to look at the common everyday outcomes that you wouldn't always capture in the chart. So she first went to busy practices and sat down and talked to parents who had kids with painful ears and fevers in waiting rooms and said, what do you care about when your kid comes in? And what are you worried about? And what are you trying to fix here? And so the things that parents identified were missing school and work, child suffering, so that we figured would be there, sleep quality. We had forgotten about that one, right? Caitlin had mentioned about sleep. I mean, I'm a parent of 2 kids, and sleep is really hard to get when kids are sick. And it's important. And then speed of symptom resolution were identified as important outcomes. So we worked those in, and we did a lot of complex analysis. But as you can see from this one summary slide, these are all the outcomes we looked at on the left, and the one I'm circling, which was a PEDS quality of life inventory that we did. We assessed every patient for, parent and patient for. There was no difference between broad spectrum antibiotics in the first column or narrow spectrum antibiotics in the second column in terms of their quality of life. And then across all these other things, missing school or daycare, requiring additional childcare, sleep disturbance, there was no difference except for experienced adverse effects. So 35% of patients who received a broad spectrum antibiotic had some adverse effect, mostly diarrhea, nausea, vomiting, or rash, as opposed to 25% with narrow spectrum agents. So there are limitations to every study. There are certainly limitations to this one. We relied on the clinician diagnosis, so we weren't prospectively verifying whether these patients had these infections. But this is the real world, and these are the patients who are diagnosed with and treated for antibiotics, so we felt that was legitimate. We only were able to, we were cold calling patients after they were diagnosed, so only 30% of patients answered the phone and agreed. Which is about where we expected, and we actually compared those who hung up to those who didn't, and demographically they were similar. The quality of life inventory might not be sensitive enough to pick up minor differences. There are always potential unobserved confounders, and whether this generalizes outside of our network, we're not sure. But our conclusions were that according to these patient-centered outcomes, we didn't find a benefit of broad-spectrum agents over narrow-spectrum agents for treatment of these conditions, although broad-spectrum agents were associated with higher rates of adverse drug effects. And we thought these confirm and extend the recommendations of the American Academy of Pediatrics to prescribe narrow-spectrum agents for most conditions. Okay, so I talked about implementation. How do we actually get this done? We now have some foundational information to say, these are the right drugs, and we have the agencies behind us to say these are the first-line recommended drugs. But I showed you that 50% of kids are getting broad-spectrum agents, and it's all over the map. And you can look at this not just in our network, or all over the place. So how do we actually change this? And this conference is about antimicrobial stewardship or antibiotic stewardship, and most people here, based on the poll, are involved in programs that do stewardship. But as I said before, most of the guidance around stewardship is in the inpatient setting, right? So IDSA and SHEA and CDC really have great guidance around the inpatient side, but not a lot in the outpatient setting. And CDC has really stepped up and started to make some recommendations here. But we wanted to see, is outpatient stewardship achievable? And so these are some of the core strategies that are recommended in the inpatient setting. Prior authorization, you can't do, right? You have 40 people in the waiting room and a kid here. You can't wait to get a call whether you're allowed to use your augmentin. But there are other things like prospective audit and feedback and adaptation of that, education guidelines, and optimizing doses that can, I think, be done and have been done in the outpatient setting. So as one example, and there are many groups who have done work like this, I'm just going to talk about some things that we've done at CHOP. We conducted a cluster randomized study in this network that I've been talking about. So we enrolled 18 practices, which had about 170 clinicians. And as I said, they were all on a common electronic health record. And we focused here, again, on antibiotic choice. We were talking about not whether you prescribe an antibiotic or not. We have a study in progress looking at that. But if you prescribed an antibiotic for one of these conditions, what did you prescribe? And again, strep throat, sinusitis, and here we used pneumonia because there was a separate otitis media or ear infection study going on. So we wanted to focus on these three. And again, the nice thing about these three is the first-line agent is Amox or penicillin, and the others are all second line. So what we did is, here is our timeline. We pulled data. We did essentially it was a cluster randomized trial, but we also used pre-post study analytics to superimpose. We collected 20 months of baseline data. And then we, myself and a group of other folks on our team, went out to the 9 practices that were, the 9 clusters, so practices that were randomized to the intervention, and did on-site education to say, okay, here, remind them of the guidelines. And here's what we're going to do. We're going to study this, we're going to look at your data, and we're going to give you some feedback reports. And you can see we gave, over 12 months, we gave 3 feedback reports about how they prescribed their antibiotics compared to others in their practice or in our entire network, and with respect to the prescribing guidelines by the AAP. So here was an example of one of those called report cards. They had one for each condition, and this is a real de-identified example. And so this is broad spectrum, your proportion of broad spectrum antibiotic prescribing for acute sinusitis. And we listed what drugs were. And you can see how you prescribed over time. So blue is baseline, first quarter, second quarter. We kept adding bars over time. How your practice was prescribing and how the network prescribed. And the idea here is to get at peer comparison, right? To leverage this idea of benchmarking and peer comparison. How are you doing compared to others? And that's, in the behavioral economics space, that's thought to be a powerful lever. And so we did this, and as you can see again over time, starting on the left 20 weeks before to 0, which was the start of the intervention. When you compare the control group is the top, I don't know if you can see the colors, is more green dots in line, to the intervention, which are the X's, the red X's, we saw a relative reduction of 50% of broad-spectrum antibiotic prescribing in those who were getting the feedback reports in the intervention, right? So this was great, but it was a research study that was funded for a certain amount of time by HRQ. We should thank them. The HRQ is a terrific organization. And then we stopped giving feedback reports, but we still had the data, right? And so we stopped, and what do you think happened? Yeah, so it went right back up to the baseline. And so we learned a lot from this, that we thought this audit and feedback, leveraging electronic health record, could be effective, but there's something else behind this, right? It seems like being watched and having an active intervention was important, because I don't think people forgot what the recommended guidelines were once we stopped sending them feedback reports. I think they knew. I think there's something here about a Hawthorne effect or otherwise of being watched. So what do clinicians actually think about this, about antibiotic prescribing, about this type of intervention? So we again, Julie Simzak, our behavioral sociologist, went out to practices and interviewed clinicians who were some who were part of the study and some who weren't part of the study, to ask them a few questions about the intervention, about prescribing. And so it turned out that most did not believe their prescribing behavior contributed to antibiotic overuse. And this is not new. This has been shown before in other populations, and we've actually shown, I don't have a slide, but Julie has actually polled people again. And when you look, generally speaking, about 90% of primary care doctors think that antibiotic overuse is a problem, but only 10% think it's a problem in their practice. Right? So those numbers don't really make a whole lot of sense. And this is a problem. It's sort of like not in my backyard. And that's something that we really have to think about when we are designing interventions and talking to folks. They reported frequently confronting parental pressure. The first thing, not just in our network, but in other past studies, and I'll show you some more data, the first thing people say, well, it's the parents wanted it, or the patients wanted it. That's why I give it. They pressured me into it. And then sometimes they would acquiesce because they worried that if they didn't give it, they would lose that patient. And this is the reality, the real world, this business model. Caitlin mentioned urgent care, right? Urgent care and retail clinics have popped up all over the place, and there's a real fear that pediatricians will lose their patients to these clinics, or they'll just go and get their antibiotics and then come back and have to deal with the complications. So this qualitative work is basically reams and reams of recorded quotes, and this is one representative quote. We have lots of parents who come in, they know what they want. They don't care what we have to say, they want the antibiotic they want because they know what's wrong with their child. And so whether this is really true or not, this is the perception of a lot of practitioners, so we have to pay attention to this. And again, I mentioned other folks have done this. This is a picture of Rita Mangione-Smith, who is a health services researcher at University of Washington in Seattle, and really a pioneer in this field then and now, still doing terrific work. And she, almost 20 years ago now, interviewed 10 doctors and 306 parents in these doctor-patient dyads after they left the room at an encounter where an antibiotic prescription was given. And here, the physician perception of parent expectations for antibiotics here was the only predictor of prescribing. So when a doc thought that the parent wanted the antibiotic, they prescribed an antibiotic 62% of the time, versus only 7% of the time when they didn't think they wanted an antibiotic. So that's powerful, but what do the parents actually think? So when she then went on to talk to these families, they were direct, and actually they had videos, there were direct parent requests for antibiotics 1% of the time. And parent expectations for antibiotics were not associated with the physician perceived expectations. So most of the time when docs thought that the parent wanted an antibiotic, it wasn't true. So there's this disconnect. And parents who expected antibiotics but didn't receive them were more satisfied if they had a contingency plan. So this idea of, okay, your child has a viral illness, and this is what you should expect, and this is what we can do if it gets worse. So that really was the key. They want an explanation for what's going on and a plan, not necessarily an antibiotic. And failure to meet parent expectations around this communication piece was a key driver of parent satisfaction. And satisfaction isn't everything, but it's important, right? You want to have a productive patient encounter so you can develop trust and rapport and have things work well. This had, like I said, 20 years ago. We did this more recently, where we interviewed parents in waiting rooms. It was part of the same study that I had showed you before. But generally speaking, parents did not planned to demand an antibiotic for their child. These are sick kids with fevers in waiting rooms. They deferred to medical expertise about their need for antibiotic therapy, and they seem to be aware of the downsides of antibiotics and seem to be generally willing to partner with the prescribers to actually improve appropriate use. So this is really important to know that this is the case. So more from Rita Mangini Smith. She did, later than, again, almost 20 years after the first work, she did surveys of providers in Seattle practices, 28 providers, more than 1,200 visits, and to try to get at, okay, so there's some type of communication event that needs to happen for appropriate satisfaction and understanding. And she found, not to get too much into it, but I'm collaborating on a study with her that she's directing right now on how to frame the encounter. So it has to do with positive treatment recommendations versus negative treatment recommendations. And I won't do it justice, but it's generally speaking, instead of saying, your kid doesn't have a bacterial infection, they don't need an antibiotic, you say, well, you know, they have a viral infection, and it's frustrating because we don't have drugs that can treat that. But here's what we can do. As I said before, here's the plan. You can expect them to have a fever for a couple more days, be coughing maybe for 10 or 14 days, but progressively get better. And if they don't, or if they have these signs or symptoms, you know, maybe they start to have a hard time breathing, or they become lethargic, or they're not eating, then you call me and we'll see them again. Those are the type of encounters that really work and make it so parents are not demanding antibiotics. And Rita's doing a terrific job of characterizing that. So I want to finish up talking about these sort of some more non-clinical drivers of antibiotic prescribing. So what I've been talking about, this parent interaction, these perceptions of wanting an antibiotic, is not a clinical driver of getting an antibiotic, right? Just because you think somebody wants one, that has nothing to do with the patient's clinical condition. So this perceived parent pressure is something we have to pay attention to. But there are other things that we have to pay attention to that show you how powerful these non-clinical drivers are. So the presence of trainees, there are a couple of really cool studies done a while back where they look at doctors in the inpatient setting who are prescribing antibiotics, and they are much more likely to prescribe an antibiotic when they're by themselves than when they're with a medical student, right? I mean, it's not shocking, but at the same time, it's crazy, right? Like, that shouldn't be the case. So they're influenced by context. Speaking of that time of day, Jeff Linder, who I mentioned before, who was at Harvard and now is a chief of general internal medicine at Northwestern, did a really great study. It's a brief report in, I think it's in JAMA Internal Medicine, a research report, where they looked at antibiotic prescribing in general pediatric practices across the time, over the day. And prescribing is lowest at 8 a.m. when people first come in. It goes up to when you get toward lunch. And then after lunch, it drops back down to the 8 a.m. levels. And it goes about around 5 o'clock, it gets higher. And they've adjusted for the type of the patient type in the presentations as we had adjusted before. So these are not different patients or more demanding patients coming in. I mean, that's crazy, right, when you think about it, but it's human nature. And it just reminds you that we are human beings prescribing antibiotics, so you have to understand human behavior and levers that affect human behavior. Patient race. So we published a study about 6 or 7 years ago in pediatrics that looked at antibiotic prescribing in the same network I talked about. And black patients received 25% fewer antibiotic prescriptions and 25% fewer broad-spectrum antibiotic prescriptions than white patients. And this is not, you know, there have been a lot of disparities that have been shown in the literature, and it can be complex, right, when you have a big team or you're talking about different underserved areas that might have different insurance type. But this is adjusted for age, for sex, for type of insurance. And this analysis was done within clinicians. So it's looking at the same doctor prescribing to patients of different race. So it's not like we're looking in one clinic in one community. So this doesn't make any sense, right? I mean, these are levers that we have to be thinking about. In practice location, the main predictor of whether you get a macrolide for pneumonia in a pediatric patient in our network is suburban location. That has nothing to do with clinical presentation, right? So these are I know I'm kind of beating a dead horse here, and I want to drive these home, but we are, you know, these non-clinical drivers of prescribing are really important. We can't just keep thinking about, okay, make sure you look and see pus behind the eardrum. It's more than that we have to educate people on. So I just want to mention 2 studies. I'll close with those that have leveraged this behavior change in behavioral economics to think about how to prescribe, change prescribing, and I've called them novel socio-behavioral strategies. So this one's great. It's another, and I think it was another short report. This one also in JAMA Internal Medicine, led by Danielle Meeker, Jason Doctor. Jeff Linder also has his fingerprints on this one as well. But Danielle Meeker and Jason Doctor are behavioral economists that work at University of Southern California. And what they did here is an intervention that they said took advantage of clinicians' desire to be consistent with their public commitments. So they call this, I don't know if anyone's ever read the book Nudge. Anyone read that book? It's a good book. You should read it. It just talks about, it's based in behavioral economics. And the idea here is how do you kind of nudge people to do the right thing? And here they called it a low-cost behavioral nudge in the form of a public commitment device. So they had a letter. It's basically a proclamation to prescribe antibiotics judiciously that they randomized primary care doctors to looking at this letter, signing this letter, and then posting the letter in their patient rooms. And there was a lot of text, and I just pulled out a couple of excerpts of it, but it's sort of like this. Antibiotics like penicillin fight infections, but they can cause side effects. If you have a virus, you won't get an antibiotic. Your health is important to us. We promise to treat your illness in the best way possible. So sort of appealing to that kind of Hippocratic oath thing. And they signed it, and they just stuck that was the whole randomized trial. You signed the thing, and they put the poster on the wall. So when the doc was going into the room, they kind of were reminded of that. And just doing that, they showed a 20% reduction in inappropriate antibiotic prescriptions for viral infections. So bronchitis was the main driver, but also things like influenza. So pretty powerful stuff. I mean, this is a 20% reduction is a huge number, and compared to some things that have been done in the past, is much larger than really expensive public health outreach and education and all types of things. So pretty powerful stuff. And the last study I'm going to show you is work by the same group, but with a much larger, more resource-intensive intervention. And this was done in more than 50 practices, more than 250 doctors across 2 practice settings, one around Boston, around the Harvard Pilgrim group, where Jeff Linder was, and one around USC in California, where Danielle Meeker and Jason Doctor were. And they enrolled practices that all had electronic health records. It didn't have to be the same platform. It just had to be electronic. And they instituted, in a sort of cluster randomized approach, 3 different interventions. So the first one was suggested alternatives. So if you coded for a condition that we know is caused by a virus, so influenza, acute bronchitis, largely driven by that, and you tried to click for an antibiotic prescription, the first one would pop up. It said, antibiotics are generally not indicated for this. Here's a list of suggested alternatives, things like cough and cold medications or humidifiers, whatever it might be. The second one was accountable justification. So again, viral condition, you prescribe an antibiotic, and what would pop up is a text box that said, you have to justify why you're prescribing this. And if you didn't justify why you're prescribing it, no justification given would populate the chart. I mean, Jeff Linder shared some funny stories about, people would just write like, because I want to, and yeah. But most of the time, they would write, well, I think, it's a sinusitis or something like that. So, and then the last one, which they hypothesized would be the most powerful, is peer comparison. And this one did not happen in real time. This was a monthly report, somewhat similar to the study that we had done, that would send you a letter, I think they did it both by email and regular old US mail, and they essentially dichotomized. And if you were in the top decile, so the top 10% of prescribers in terms of how judicious your prescribing was, you got a letter that said you are a top performer. Everybody else got a letter that said you are not a top performer. And so he jokes about, like, how do you think all the Harvard doctors felt about getting a letter that said they're not a top performer? And lo and behold, when you look across, and they did them all in isolation, and then they did combinations of the 3, and a very complex analysis, which was really terrific. And you can see accountable justification, peer comparison, and suggested alternatives, all the orange bars, if you can see them, are the intervention groups, all showed a reduction in antibiotic use. Peer comparison was the most significant and most profound. And this was actually really impressive because the prescribing rates they started with were really low. And as you can see, and I don't know if you noticed from the study that I showed you in our network, things were already going down before the intervention. So once the practitioners knew they were in a study and knew they were being watched, things were already going down. So the bar to move this further was pretty high, yet they still moved it further. So to summarize, antibiotic prescribing in the ambulatory setting is common and can be harmful both to the patient, this individual harm, as well as society, this public health risk that we all know about. Broad spectrum agents are probably not better than narrow spectrum agents for most conditions, and they cause more harm. Audit with feedback can be an effective strategy to improve prescribing. Showed you in a couple of different studies where this peer comparison works, and then other socio-behavioral approaches such as improving communication, holding clinicians accountable, and applying some of these behavioral economic nudging principles can be effective. And so I'll stop there, and I'm happy to take any questions. Or I can take them. I don't know. I think we have a panel after too. So whatever.
We do. I have just maybe one question to start it off. I think we have maybe 4 minutes maybe for questions. So thinking about the concept of optimizing, not withholding antibiotics, and say the patient story situation where perhaps an antibiotic was appropriate, but choosing the right antibiotic, topical versus systemic. You know, I think some of the feedback we have heard just through some of the surveys that we've done in general interaction with healthcare providers is there's a role for, say, prescribing guidance, but people don't necessarily want to be told how to prescribe. So do you think there's a value of talking about optimization when we talk about stewardship so that people don't think we're saying you do it or you don't?
Yeah, that's a great point. And so this is something that I try to proselytize on the inpatient side, but also on the outpatient side. This is not about restriction or rationing of antibiotics, and I'm so glad you brought that. It's about optimization, right? So it's about doing the right thing, and it's really about quality improvement. So if you think about it from that lens, I want to do what's best for the patient. It's the way to go because it's a sell and it's a win for everybody. And with antibiotic stewardship, 9 times out of 10, doing the right thing for the patient is actually either not giving an antibiotic or giving a narrower spectrum agent or a shorter duration or de-escalating. So it just works out that way. We're not in the position, I mean, you could argue from a public health standpoint that we're almost in a position where we need to ration antibiotics, but you don't need to. Right? We have enough evidence and enough data to just say, what's the right thing to do? And if you do the right thing for the patient, it almost always works out that way. So I think that framing is so important. And it can really change, it can be game changing when you work with, like I said, I direct our inpatient stewardship program, and we work with folks in the neonatal ICU, in the surgical wards. All my clinical work is in transplant ID, so it's bone marrow transplants, solid organ transplants. And we work with those teams to say, let's figure out what the best regimen is based on the evidence, and let's study it and follow it. And it's almost always shorter. And we have, and I think building on it even further, we have interventions where we actually say, wait a second, you need to get antibiotics faster and broader spectrum for example, patients with sepsis. And that helps, right? Because it gets you some street cred where you're saying, listen, we are really optimizing and we're trying to figure out, so start with that principle of what's the best thing to do for the patient. And like I said, 9 times out of 10, it will be fewer days of antibiotics. Yeah.
So we spend a lot of time talking about trying to fix things upstream, and we spend a lot of time also dealing with the repercussions of patient satisfaction as far as reducing outcome or making outcomes worse, especially with opioid prescribing. And so do we think that there's a role for getting rid of Press Ganey and getting rid of patient satisfaction scores as it relates to improving antimicrobial stewardship, especially when you look at, parent expectations drive prescribing habits?
Yeah, it's a great question. I don't know enough about that space to really, but I'll make some comments, right? So for one, when you look at the Press Ganey scores, in our practices in our network, it completely disassociates from appropriate prescribing. So some of the best patient satisfaction in our practices that overprescribe antibiotics. I would, so that makes you think that it's not, at least with respect to antibiotics, it's not helpful and it shouldn't be there. That said, I think some of the work that I talked about that Rita had done shows that there's a way to make patients satisfied if you explain to them what you're doing and why you're doing it. So I think those two things aren't mutually exclusive, and you can, if you approach it in the right way with this open-minded attitude to say that they're not, parents aren't, or patients aren't just coming demanding an antibiotic. What they demand is they want to know what's wrong with them or what's wrong with their child. And so I think you can have your cake and eat it too in a way, and sit down with patients. And I at least personally, anecdotally, have had some satisfaction here, what seems like good patient satisfaction. We sit down and you say, oh, okay, here's what we need to do. And I wish we had this, but we don't. And if you spend the time and you tell them what their diagnosis is, and when you're transparent about it, and you talk about and quantify the harms of antibiotics, I think you can get satisfaction there. So, maybe it's that we need to tweak how those things are rolled out and implemented and what the questions are, but they probably can both exist.
Okay, we had one more question here.
I know that we have an ambulatory focus today, but you had mentioned sepsis, and this is something that I'm struggling with as a stewardship program manager with our sepsis group. I know that there's a CHOP protocol. We're still waiting in particular for pediatrics in 2019 for the new sepsis guidelines. How do you align stewardship with sepsis, meeting core measures?
Yeah.
Is the first dose a big deal? I'm getting a lot of feedback, and it's like, how do we treat sepsis? And at the same time, how much C. diff can we bring to the world?
Yeah, it's a great question. So I'll sort of address in two ways. The first one is, again, this is about optimizing patient care, and in some situations, you got to get broad spectrum agents to patients fast. And that's a truth. The problem with this is my perception of the problem with a lot of the sepsis measures that are coming out is that the pendulum is swinging way too far. So all sepsis is not really sepsis, right? So the data that these measures are based on are generally retrospective studies of patients with severe sepsis or septic shock. When you rule a patient out in the hospital, patient has a fever, and you get an antibiotic, you pull a blood culture, hopefully, and you give them antibiotics. 9 out of the 10 of those patients don't have septic shock, right? So the problem is focusing on the patients that are truly sick or at risk of really, really bad outcomes. I can tell you right now, we're working in our hospital, everybody with a fever and a central line is getting, they're timing their antibiotics and getting them stat. Those patients, some of them don't need any antibiotics, maybe a blood culture, but so I think what we need to do is focus on the patients who are really going to have a bad outcome, and then get them antibiotics fast. And then once the appropriate cultures are taken, de-escalate very quickly. If you do that, this is a small proportion of patients. I don't think you're going to have a problem. And we can get rid of lots of extra vancomycin and piptazo and cefepime use that we don't really need. So I think there's actually an opportunity there. It's a little bit of a tough hill to climb, but there's an opportunity in these sepsis measures to go in, and so we're shining this spotlight really broadly on patients. Shine the spotlight on the ones who need it, and then actually there's an opportunity to stop giving broad spectrum antibiotics to patients who really don't need it. So there could potentially be a win there. And I don't know if I'm saying it clear enough, but I think that we just have to be careful. There was this measure, 10 years ago in adult medicine, where all of a sudden everybody who had pneumonia coming to the ED had to get antibiotics within 6 hours. It was a complete disaster, right? Because all of a sudden everyone just would come in and they just slam antibiotics into patients before they actually made a diagnosis to meet a measure. And so I can see something analogous happening with sepsis, and I think we're not, we're reacting to data that we're over-extrapolating, and then anecdotes of situations that have been horrifying and bad, like the incident that happened in New York, but the measures we're doing in the hospital are not addressing that type of sepsis recognition. We just have to be careful how we implement those.